Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
I'm Kayla Graham. I'm a PGY4 at Atrium Health Carolinas Medical Center in Charlotte, North Carolina, and the Southeastern Section representative to the Residents and Fellows Committee with the AUA. And today on the AUA Inside Track podcast, we'll be introducing you to a unique aspect of resident curriculum at the University of Iowa. Dr. Ryan Steinberg has created and implemented a point-of-care ultrasound curriculum that he'll be sharing with us. And he is accompanied by Dr. Brent Yelton, a resident at the University of Iowa, who is well-versed in the POCUS curriculum and its use in inpatient care. You guys want to start off by giving us a little bit of introduction and a little bit of info about yourselves?
Awesome. Well, thank you very much for having us. So my name is Ryan Steinberg. I'm a clinical associate professor of urology at the University of Iowa. I did my medical school at Rush University in Chicago and my residency training at the University of Iowa, and then a fellowship in endourology at UT Southwestern Hospital. And I've been a practicing urologist at Iowa now for 5 years.
And I'm Brent Yelton. I did my medical school over in the Metro Detroit area at Oakland University, and I'm entering my PGY3 year at the University of Iowa. Future aspirations are to go into kind of endourology, minimally invasive surgery, hopefully fellowship in that, and then kind of see where things go from there.
Awesome. Well, thank you both so much for joining us and sharing a little bit about your POCUS experiences with us. So to start off, Dr. Steinberg, what inspired you to create and implement this curriculum in the residency education?
Yeah, so I, as I mentioned, I'm a fellowship trained endourologist, and my fellowship focused a lot on kidney stone, advanced kidney stone surgery, and particularly PCNL. And we did all of our access under fluoroscopic guidance. And it was really towards the end of my fellowship that there were multiple reports coming out, and ultrasound guided percutaneous renal access was starting to gain traction thanks to Tom Shee and some others who were publishing work in that. And so I definitely had an interest in applying point of care ultrasound to my surgical practice. But in addition to that, as a new urologist out in practice, as well as somebody serving a largely rural population, I was seeing how these patients were coming to my clinic, oftentimes with, traveling 2 hours, 2.5 hours each way, and then having these very long clinic appointments where they'd have to go to radiology, get an ultrasound, get an x-ray, come wait in my waiting room, come and be roomed. I'm running 15 minutes behind, see me, and it turns into this long escapade. And so in trying to find a way to not only improve patient satisfaction, but also to reduce the length of the visits, felt that as I was exploring point of care ultrasound, not only in the operating room, that the clinic seemed to make a logical place for us to sort of explore some of that. And in thinking about not only how I could employ it into practice, but ultimately how I could teach it to the trainees at Iowa, felt that focusing too much on a single procedure or too much on a very specific facet of ultrasound within urology, in particular, because the ACGME does require what they consider to be a full breadth of understanding of ultrasound use in urology, that any sort of education that I'd want to provide to our trainees should really, run the gamut of as many urologic organs as we can image with point of care ultrasound. And so it was really both, advancing and improving my own skills in the operating room, utilizing it in clinic, and then trying to take what I thought was an important skill, to teach the residents, and ultimately apply that to creating something that could be hopefully sustained, but also could be thorough and complete for all of our trainees.
That's awesome. Can you describe for us how that curriculum begins? How is it built into resident education? What all does that entail?
Yeah, so we'll be doing our third year of our ultrasound curriculum in a couple of months this fall. It has definitely undergone a little bit of a change over that time, which is good, right? You know, all good things ultimately are honed and are adjusted as we learn more and more. And originally, when we did this, we did it as 6 separate modules, which we still kind of compartmentalized the curriculum into. One focused really on the basics of ultrasound and ultrasound imaging, and then 5 separate modules, excuse me, for the various urologic organs: kidney, bladder, prostate, penile, and scrotal. When we originally did this in year 1, we did it in the evenings, 1 month at a time, where we would focus on one module each month, so completing the curriculum in 6 months. The adjustment that we've made is we've now implemented an intern boot camp for our interns. And so we've compressed this now. Instead of, a few hours for one organ or not, we do half of the modules over the course of one afternoon, and then over a second afternoon do the other 3 modules now with our interns. The modules themselves and each segment of the curriculum is pretty similarly structured. The idea is that the residents take basically a quiz that assesses their baseline knowledge of ultrasound that is appropriate, for that organ or module. Once they complete that, they actually have access then to a narrated video, which is a lecture style video running through PowerPoint slides that provide all the salient features needed for education, for that ultrasound module. So say for the kidney, it would talk about which probe you would use, what are the indications for it, what are the technical considerations of completing and doing an ultrasound for that organ. And then what are the common physiologic findings, pathophysiologic findings, and ultimately provides a little bit of education about the necessary documentation and billing for that as well. There is a narrated PowerPoint as well as one for the residents to look through on their own if that's a preferred learning medium for them. And then once they complete that review, they would then take a post quiz to assess their knowledge. And this was all done amongst the residents prior to coming to our in-person sessions. So usually within 1 to 2 weeks. And then when we would have our in-person hands-on sessions, those were really focused on getting people's hands on the ultrasound probe. So we may have done a brief 20-minute review of some of the salient features from those lectures, particularly the technique of ultrasound and some of the physiologic and pathophysiologic findings. At which point then we would have multiple ultrasound units set up with various ultrasound phantoms. The residents, I was sort of hoping this is how it was going to go, but we're always very excited to scan each other's bladders and kidneys. I've never seen somebody more excited to see a ureteral jet than one resident scanning another resident. And so, for some of these modules that obviously was appropriate, the residents themselves served as the appropriate models. And then once we did an opportunity for each resident to kind of work and practice, not only utilizing the ultrasound machine, but also obviously scanning whatever it was, then we performed an assessment, either myself or one of my partners who would actually watch them perform those skills, and then we would ultimately assess a score based on a validated metric to assess their ability to work the ultrasound machine, obtain the salient images, describe them, and whatnot like that. And so we completed these assessments. Like I said, initially over the 6-month period. We needed a little bit more time because, as you can imagine, the senior residents did not want to be left out with the junior residents. So our first year, we put 18 residents through the curriculum, which is, as you can imagine, a lot of people with each session. Now that we're doing it with our intern boot camp and people have been through it, getting 3 to 4 residents through at a time is a lot easier to do. And then once they have completed their curriculum, We actually have a unit, and I think Brent will speak about this a little bit later, that they're then kind of authorized or felt to be trained to use on the inpatient side. So.
Awesome. And was the radiology department involved in creating this in any way, or was this done totally by urology faculty?
This was primarily my doing, and then Dr. Chad Tracy is one of my partners, also in endourology, who really spearheaded the prostate ultrasound section, um, as he's a high volume prostate cancer and BPH surgeon, and so we did not include radiology, not because they weren't willing, as much as we really wanted to keep it focused on urology salient things. Um, and so we did specific online trainings and hands-on trainings through offered often by the AUA, as well as utilizing it, in the operating room and those things, and kind of considering the key features with each of these modules ultimately led to the construction of the various lectures, and then those obviously downstream led to the quiz creation, and then the important features that we felt needed to be tested for the hands-on portions.
Okay. Are you primarily using a butterfly handheld ultrasound device, or like wheeling a whole ultrasound machine with you? Kind of both of them?
Yeah, so we have we're very lucky. So in the operating room, we have a full-fledged BK machine. So and that obviously allows for the full array of various probes, curvilinear, linear, that we often would use for these types of things. So intraoperatively, we use those. We're very lucky because we have that for in the OR, which probably provides the best image. But we do have our hospital, University of Iowa Healthcare, has invested in integrated butterfly actually into our Epic ecosystem. And so we do have a butterfly unit that's available right now primarily for inpatient use. And so we have a butterfly unit that's 20-hour available 24 hours a day to the residents or the staff, that they can go in and do studies for patients on the floor. And then at times we'll do them also still in our clinic. Some of the technical integration is still happening, on that end, to be able to offer it sort of institution wide.
Brent, when do you find that you're most able to implement the POCUS into patient care?
There's been a few different ways. I think the most common way I've been utilizing it is anytime we get like a hematuria consult. A lot of the times, whether they're transferred from another hospital or it's an inpatient consult, you're kind of going in blind, like, okay, how long has this been going on? How severe is it? What catheter do they have, and if they have one? And I've been really using POCUS to kind of identify like risk stratification. Okay, so this person has this catheter in, I can fill their bladder up. I can look around. Do we have a big clot burden? Do we have a no clot burden? Do I need to put the patient through upsizing a catheter? So hematuria has been like probably the main one that I've been able to use it with, because it just gives me an initial kind of evaluation of the patient, whether there is a big clot burden, what do we need to do for them? Is this not severe, and where to go from there? But really, it's kind of been used all over. Anytime we're just not sure about something, it's like, well, can we focus and figure it out? There's been occasions with patients with ascites who get bladder scans that are potentially inaccurate due to the ascites, and we get a catheter in and we don't get anything back. We're like, well, it flushes. Is it in the right place? Easy enough to throw the POCUS on, increase the depth a little bit, and make sure that we can fill and empty the bladder. All right, we have a catheter in the right place. That's not the issue. Even post stenting stone where we don't see the creatinine dropping, it's easy to throw it on the kidney and say, okay, well, no hydro. So it kind of comes up situationally, but I think probably the most utilization we've had so far is in evaluating hematuria patients to try to figure out exactly what's going on without having to put them through the radiation of a CT scan or waiting for an ultrasound result.
Where do you keep your ultrasound equipment to be able to access it whenever you need inpatient?
It's great. It's right in our resident room. We got our iPad charger with the butterfly charger right next to it. So it's super easy to grab. It's very accessible. I think most of the time when I'm on our night float rotation, I'll just like put it on my desk. So it's like there, and anytime I'll have it, I'll just take it with me if there's any question that I might need it. But right in our resident room makes it really easy to use. It's always accessible, which is really nice.
Brent also minimizes his use. Just the other day, patient with a bad bladder neck contracture and pulled it out, and they put a suprapubic tube in. In a patient who had prior abdominal surgery, got a clear window, put a needle in, put a suprapubic tube in under direct vision. Nobody has to worry or fret about, a blind passage of that tube, because he could just put the ultrasound right on there and watch the whole thing happen.
And like the more you use it, the more confident you become. And so even, I mean, I've had PCNLs with Dr. Steinberg where we do ultrasound access, and that may not be what I've been using it for before, but every time you're using it, you're just like getting more adept to adapting depth, adapting it, making your image better, knowing what you need to see. So your skills just kind of get enhanced no matter which way you use it, but the applications are pretty diverse, and pretty much anytime you're just like, well, what's going on? I think we've even used it once we had an ICU patient with an enlarged testicular mass, and we're like, well, let's just take a look. I mean, we have it, we brought it up there, and me and one of the interns last year did an ultrasound of it, and we're like, yeah, that doesn't look good. I'll admit we weren't confident enough at that point to not get a formal ultrasound, but we knew something was wrong, but we wanted to confirm before we started doing more stuff. So
yeah.
But with that, even if you're not sure, they were going to probably end up getting an ultrasound anyway. So it's just a way to kind of test your skill and then look at the result and say, like, oh, we thought the same thing. Gives you more confidence the next time.
What have been some challenges with implementing POCUS in patient care?
I think from the resident side, the only big challenge you face is there's like a small time burden. And really, I think once you get in the flow of it, that's pretty minimal. But let's say you got like 3 consults that are somewhat urgent, and you're like, do I have time to bring this over, enter the patient information, do this before going to see the next person, or should I just kind of keep moving on? But really, I mean, that's like the only minor burden. And once you get efficient at it, you can really, like, the patient information, it's an MRN, it all goes in. You can do your ultrasound, put it as a draft, and then at the end of your shift, just be like, okay, I can enter the information now. So not really a ton. There's not anything that really inhibits you from using it. It's easy to carry. I mean, it's just the iPad and the thing. You can take it anywhere around the hospital with ease. So not much. I would say time burden mildly, but really other than that, nothing.
Yeah, I think that I think just like implementing any new technology into practice, there's always going to be, oh, but I was doing it like this, and look at how efficient I am. And it's going to take a little bit of time, like what Dr. Yelton was saying. And I think that if you choose to commit to that, I think it actually, maybe in the short term, just like any learning curve, there's a time commitment. But I think in the long term, it often is well worth it. I also think that there's a little bit of hesitancy sometimes from residents and or faculty with respect to, well, if I do this, what if I miss something? And I think that sometimes, beyond, I guess, the simple things like we don't have an ultrasound machine, or I don't know how to use it, things like that. I think there's a hesitancy about the legality and liability of it. And I think that you just need to know your own limitations. And while you may do an ultrasound, as Brent was mentioning, for a testicular mass, that's great. That shouldn't necessarily, at least early, especially early in your learning curve, replace doing a formal radiology ultrasound, but it provides you an opportunity to sort of learn. And I think it's also important that in any report that you put together, if you're not sure, you don't have a clear picture of certain, facets of things, it's okay to acknowledge that. You don't have to bill everything as a complete retroperitoneal ultrasound and get both kidneys. If you're looking for hydronephrosis on the left kidney, you say there's no hydronephrosis, but this is limited by the fact that we were not assessing the full parenchyma for masses and other things. I think that there's a way that you can clearly state it, that the point of it was not to look for everything. It was to look for this very focused feature that is actually important to what you're taking care of right then and there. And so I think that there are definitely ways that people can phrase it and ultimately feel comfortable providing the information, providing the service without the fear of the liability aspect. So,
Do you find that because you can be fairly specific about what you're looking for, that this is generally replacing other radiology studies?
that's a really great question. I will tell you that that is going to be a very individual level of comfort. Do I think that a bedside point of care ultrasound done for a testicular mass should replace a standard radiographic one? At least at this point, no. And I'm not really sure that I would ever feel that that would be the case in the future. Um, but I think that uh, we talk a lot during the curriculum and in the modules, what are the indications? So we give the absolute indications, but we also talk about kind of the relative indications, um, for what really it probably is most salient and important for, and what you really shouldn't do. I don't think that I would trust myself or anybody else, and I'm sure there are people that feel differently that say it's okay, I'm going to follow this renal mass and I'm going to do serial surveillance and I'm going to do a point of care ultrasound every 6 months. And if you're really facile at that, just like there are people who are great at certain things and not great at certain things. I think overall, you just need to be thoughtful about what you use it for. So I don't think it will ever completely replace the radiology ultrasound, or the ones done in radiology, but I do think that um, this is a great way for some of our standard follow-up low risk ones. I did a ureteroscopy, I took a stent out. Now I want to follow up and look for silent hydronephrosis. And God, how many of those do we get? And there's no hydro and everybody's happy, and how much do we overwhelm our own hospital systems with those things where we can offload for them, provide billable services to ourselves, and also improve the patient experience, and so I think as long as you're thoughtful about it, it can be a nice addition, not necessarily a full replacement for what's done in radiology.
Yeah, absolutely. And especially like you were talking about in the beginning, patients coming in from far away, it saves them an extra visit to a radiology office, or at the very least, half their day coming to see you and follow up. So I think that's great. What is your, what has your partners and other attendings' perception of this been? And are they implementing it more now that the residents are all trained in how to use POCUS?
Yeah, so that's a really great question. So first and foremost, all my partners and everyone at Iowa has been very, very supportive in doing this. From the perspective of trying to ensure that there's consistency and quality assurance that goes and is fed back, particularly in the studies that are done. At least to date, I have personally read all of the studies myself. So even if someone else is on call and Brent sees somebody in the ER, those images come to me for review. There are other faculty who have shown an interest in potentially utilizing point of care ultrasound. So Chad Tracy, one of my endourology partners, is one of them. Amanda Swanton is a partner of mine who does men's health and actually already is implementing and utilizing penile ultrasound as part of her evaluation for erectile dysfunction. So she was extremely happy when the residents walked in and were like, "Oh yeah, but we're looking for this," and could kind of move the machine and had already seen that for something that is not obviously a very common use for point of care ultrasound, like kidneys and bladders and things like that. So there are definitely others who are interested and others who are interested in getting involved. And it's definitely possible before we would have them formally sort of review these and kind of take ownership of their own studies, that they would potentially even have to complete our curriculum and our course just so that they're sort of up to speed. But the interest and the support has definitely been there thus far. And we look forward to expanding our use not only at Iowa, but obviously elsewhere as well.
Brent, what is the resident attitude towards increasing the use of point of care ultrasound?
I think it's generally positive. I think it's a somewhat individual thing. Some people are very passionate and excited to get involved, use the ultrasound, want to do it. Others less so. But I mean, I think the more that people use it and they see the utility in it, the more it kind of like catches on. when you go on your morning rounds and you're like, hey, like we have a gross hematuria patient, we like did an ultrasound, there's no clot, or there is clot, and then that's verified later on with what happens to the patient. There's like more confidence, and people are like, okay, we're able to make a important clinical decision based on what we did with ultrasound. Then I think more people get excited about it. They see the utility in it, and then they also want to get better at it. So overall, I think the majority of people are pretty excited to use it, and the curriculum has been great. And then I think they'll just continue, especially with having each intern go through the boot camp, get integrated into it. And then with the older people who just went through it 2 years ago, now increasing the utility of it and seeing how it's used, I think it'll just continue to grow.
I'll also add one other shout out to that. So when we developed the curriculum, we ended up not just rolling it out initially in Iowa. I do want to give a shout out to Russ Koretz, who's the program director and an endourologist at Beth Israel Deaconess Hospital in Boston, is one of my collaborators. So when we put the residents at Iowa through the curriculum, he similarly put his residents in Boston through the curriculum, and so we've submitted for publication the curriculum and the outcomes, all the stuff that we've been talking about, the actual data behind it is submitted for consideration now. But I just mentioned him because I would get text messages from him saying, the residents are keeping track and they're logging, they don't have a integrated butterfly system where they're at, they're tracking these cases and they keep bringing me all these lists. They're so excited. The feedback I was getting was how excited, how much that they were really buying into it and utilizing it where he was at as well. And so besides for giving him a shout out as a major contributor to, our work and our study and implementation, just that, this is not necessarily just an Iowa thing, but something that, another center has already bought into, done, and they're similarly doing yearly trainings for their new interns as well.
Even just hearing you guys talk about various scenarios you've used it in, I can imagine how much more efficient and helpful it would be to just have one that you could pull out of your pocket and do some studies, get a quick answer rather than having to wait a few hours for the patient in the emergency department to have an official study done and get on with your day and with your patient care. So I can imagine that that's an exciting thing to see in real time.
And we're lucky because, I don't know if it's the same for you at Atrium, Kayla, but so many hospitals don't have an ultrasonographer at night. So your option is CT or not, right? And sometimes they're at home and they get called in. So, just like you were saying, nice not only to provide more expedient care, but also the opportunity to provide something that, frankly, not every hospital can even offer on an official radiology basis at nighttime too. So.
Yeah, and one thing I would add too is I've had a few situations where it's like patients who are very medically literate and kind of like want to know what's going on. And it's great when you can like turn the focus and be like, hey, this is what we're looking at. Like that's the clot we have to get rid of, or this is what we're worried about. And I think they do really appreciate like live you talking them through what you're looking at, and you're looking at the same screen with them. And I do think it does provide a nice benefit to patient care where they can talk with you while you're doing the ultrasound versus, they sit through this whole scan, they wait for you to come talk to them, you review images. I've definitely had multiple experiences where patients were very happy that they could just like talk through exactly what you're looking at. You can kind of show them exactly what you're talking about. And I think it improves their care and just their understanding of what's going on.
So I think Dr. Steinberg, you mentioned that you read all of them. Is performing and reading the ultrasound billable? You're the only one who is doing all of that right now. Do residents have to be supervised for that to count? How does billing work for this?
Yeah, so we've talked with our folks at Iowa with regards to billing and all that. So we do not have to be, staff do not have to be immediately present for it to be billable. Yes, we do bill for many of the studies. Through the butterfly interface, there's an opportunity where you can actually demarcate a study as being, clinically relevant part of, decision making, part of the official medical record, where those studies I'll review, they get read. Those reports and everything, even the images, are integrated into Epic, and that does drop a billing charge, so it is billable. So there is a potential financial incentive, obviously, for those, but there is also an opportunity to note the studies as for educational purposes only, where residents would still generate a report. It comes to me, I do quality assurance, I give them a report, but it does not drop any billable charges. And so, it does still provide an opportunity for people to be able to do these studies without saying, hey, doing them for unnecessary reasons. They can just do them for educational reasons. So not everything has to be billed out, but that is an option. It is something that it is doable, and is obviously a perk, if you will, of being compensated for our time and our expertise. It's something that I try to instill in the residents and say, you're not feeling a lot of the love now, but when you go out into practice and you start doing this routinely, you're going to feel that love too. And that's not obviously the only reason why we do it, but it is nice to have skills that take into account not just our expertise but our time. But obviously, we do it because it's the right thing to do those studies. Try to keep patient care and assessment as expedient as possible.
Or any other residency programs that may be interested in creating a similar POCUS curriculum themselves, how does someone begin?
I would strongly encourage nobody to make another POCUS curriculum, only because of the fact that it obviously was it was a labor of love on my end. It was something that I really do truly believe in, and the reason why I tell people not to do it is I'm not a big fan of reinventing the wheel. I have, in presenting this work at AUA, in publishing this work and talking about it in other venues. There's no cost or payment or anything like that. If somebody's interested, they can literally have the entire curriculum. And I've shared the curriculum now with a couple of other institutions, University of Texas, Houston, WashU, Indiana. There are others who have approached me about utilizing the materials. And I think that if you're an institution that has an interest and a local champion and somebody who believes in this stuff, don't waste your time. Don't make all the new materials. Don't do all that. I will give you all the lectures. I will give you all the slides, the quizzes. Russ, my collaborator, Dr. Koritz, he and I often, for all these sites, if they're interested, we have a Zoom with them to kind of talk about the way that they structure their education. Because the way that he did it and the way that I have done it, there's always going to be larger residencies and smaller. So there's always going to be nuances to how you can best implement these things. And so we really want to work with each institution and each person who potentially contacts us to say, how can we help you to succeed? And what's the best way to implement these things? What are ways that we can make suggestions on how you can buy these phantoms, or talk to your institution or your department about getting the appropriate probes and things like that? And how can you stimulate interest? We want this curriculum to succeed, and that's not just locally or just for ours. We want this to succeed everywhere. And so, even if that means somebody decides that they don't want to listen to my voice for however many hours doing the narrated lectures, which I don't blame them, I wouldn't either. Somebody else can use the materials. They're more than welcome to adjust them, as they see fit, and as ultimately, hopefully, it would provide the best basis for knowledge for residents or trainees or others that would be interested. So if people are interested, I'm always happy to talk to them about how to create their own, but I would strongly encourage them not. They're more than welcome to have all of my materials for free.
That is fantastic. In closing, what do each of you want listeners to take away from this episode and from learning about your implementation and use of POCUS in urology patient care?
Brent, I'll let you go first.
I think from the resident perspective, it's just a really dynamic tool that you'll learn to apply to clinical situations frequently. So far for me, it's been hematuria patients, but then the more you use it, the more you realize you can apply it to a lot of other situations where you're just not sure, and you realize you have a tool that's right there, transportable, that you can get other answers with about a patient. And honestly, it's just a lot of fun. A lot of times you get to do it with your co-residents. You're using a consult together. I think one of my favorite memories is we were trying to get a clot out of a bladder, and it was me and another resident. We were like literally aiming the Foley via ultrasound to try to get it out. But it's just a great tool. It's really enjoyable, and I think it does improve patient care. So, and the more invested you are in it, the more utility you'll get out of it because you'll enhance your skills, and then realize you can use it for things you didn't even expect or in situations you didn't think, and it's great.
I would, in closing, I would tell you for many reasons that everybody needs to take this curriculum, but more importantly, everybody needs to learn POCUS. And the reason why I think is very straightforward. Technology is going to keep advancing, and we're already seeing lots of ultrasound-based technology being implemented. We see high intensity focused ultrasound for prostate cancer treatment. We're seeing John Harper and Matt Sorensen at University of Washington and breakwave lithotripsy repositioning stones and breaking stones in the office. These are technologies that are coming that people need to know, or that are here, excuse me, but there will be more that are coming. And they're ultrasound based, and they're ultrasound based and to be employed by people who know how to do ultrasound. And I would say not only so that you can best learn this as a trainee, hopefully, or out in practice, however it is, you don't want to be left behind with some of these technologies. So I think the sooner that you tell yourself, hey, I'm going to learn this, this is important. I think that that is key. And I think also so that we don't lose these technologies to other specialties. The American College of Emergency Medicine has a standardized POCUS curriculum for emergency medicine residents. They have fellowships in emergency ultrasound. We in urology, in my opinion, are frankly behind on this. And if we don't adopt it, the ER is going to stop calling us. They're going to buy a breakwave lithotripter. They're going to displace a stone off the UPJ. They're going to start managing stone disease, doing these things, which, I hope that they don't. But I think the easiest way to not let them encroach and others encroach on things that are urology-based diseases that we know how to manage and we know how to care for is for us to, jump in with 2 feet and learn this technology and learn the key components, right? Learn the ultrasound, the technology and the specifics. Those are that's the end game, and you can always play around with each individual technology or equipment to fine tune with what you're trying to do. But learn the ultrasound, learn that piece. And then if you know the basics and the fundamentals, the rest of it will be easy. And we will push ourselves forward both, individually in terms of patient care and what we can offer, but also, as an entire medical specialty in terms of what we can offer and how we're going to protect some of our own territory to ensure that these are patients that are going to continue to be managed by us and not by folks who don't fully understand some of the disease process. So while it's fun and it is awesome and it is so exciting to watch the residents, educate them and teach them how to do it and watch them, like Brent, be able to do these cool things. I think it's really, really important for our future that we adopt these skills now.
While it sounds fun, it sounds like a great experience to learn it in residency and then be able to translate that to so many additional experiences in clinic and just overall patient care. So thank you both for joining us today and for sharing your experience on the podcast and also being willing to share it with all programs around the country who may be interested. We'll share your contact information with this episode, and hopefully we can spread the POCUS use and awareness to more programs besides yours.
As one of our other residents at Iowa would say, I now believe in the hocus pocus. So just remember, everybody, hocus pocus.
That's awesome.
Thank you again for having us and for letting us kind of share some of this stuff with you.
Yeah, absolutely. It was a great conversation. I appreciate y'all's time.
Thank you.
This has been an AUA News Inside Track podcast, brought to you by the Residents and Fellows Committee. For more information about the AUA and AUA membership, visit auanet.org/membership.